Thank you. So, good afternoon, everybody. And it's my proud privilege to present this presentation on utilization of non-pneumatic anti-shock garment in India. And I thank Michelle for giving me this opportunity. Now, the first time my introduction to non-pneumatic anti-shock garment happened in 2008 at Delhi in an international conference, none other than by Professor Sulen Miller. And as it was included in the workstation of postpartum hemorrhage, I learned about it. Now I had an opportunity to conduct more than 100 workshops all over the country for a period of 3 years when I was a chairperson of a Safe Motherhood Committee of Foxy. Then I had a opportunity to visit the different states and spread it over in other states like Karnataka, then Madhya Pradesh, Rajasthan, Orissa at a state government level. And it is available in all medical colleges and district hospitals, particularly in Tamil Nadu. Now, Tamil Nadu is the first state to start using non-pneumatic anti-shock garment, which was introduced by none other than Professor Iyer in 2003. And the number of NASGs available in each center is like this. The primary health center has one, the Taluka hospital has two, the district hospital has two, medical colleges has three, and corporation hospital in metro cities like Chennai has one. So this has benefited them to, I think, give it back. Suppose if the patient is transferred with an anti-shock garment on her, they just gave the replacement unit. So the other facility was not divide of NSG at any given time. And one more advancement they have done is it is also available in a 108 ambulance. Now 108 ambulance is the initiative of Government of India to shift the mother. So it is particularly for maternity and child health services. Now, when I conducted a workshop in Jodhpur, which happens to be in Rajasthan state, in 2014, they trained the district healthcare workers and they have distributed NSG today. So they are doing it in a big way and almost 7 to 8 districts they have distributed. And they found it very useful and it has really helped to bring down the mortality in that state. The Bangalore Society of Obstetrics and Gynae, we introduced non-pneumatic anti-shock garment to corporation hospitals, peripheral hospitals, and the district hospitals. And again, training was done in the presence of Professor Sulen Miller to almost 100 obstetricians and 50 medical officers who are working in the periphery. And collectively, we donated these garments to peripheral hospitals and we also trained those medical officers. Now, these peripheral hospitals, we used to have a lot of referrals, the cases of postpartum hemorrhage, and we thought that it will be apt to train them and give them this garment. Then in Maharashtra, there is a district called as Dahanu, and it's a tribal area, and they have a prevalence of thalassemia and sickle cell anemia. As it is a tribal area, the marriages and the relationships happen in incest relations. So the incidence is very high. And when they are pregnant, even if they bleed like 200 or 300 ml, they go into shock. So again, I was invited by ICMR to train the medical officers in Dahanu district because it would help them for referral. And the nearest place for them to refer all these cases is Mumbai, which is very far. So at least with this, they believe that at least the mother could be shifted in a stable condition. They are doing the screening for them and they are the guiding force from them, and they try to convince them that how the major, who is minor, and if they marry, two major people marry each other, what problem or minor. I mean, all those genetic counseling is done there. Now, in Maharashtra, all of us, we know about Dr. Poonam and Wardha district, Nagpur and Nashik districts. They are following this PPH bundle, and the MMR has been reduced to 37 for Maharashtra. And when I learned from Dr. Poonam, I came to know that for Wardha district, it is 16. And I think it is doable still in our developing countries like India. And then in Dr. Mahale in Nashik in Pravaranagar Medical College has trained, again in periphery, almost 40 doctors are trained and been provided with anti-shock garment. Government of Odisha have given me statistics that they could save 400 mothers by applying this under the guidance of Dr. Shama Narang from 2020 to 2022, that is over a period of 2 years. And Orissa is also again a little backward state and they have a lot of tribal areas. Now, the Kerala, which is the state, where 100% literacy and the MMR is 19, and they have introduced NASG in areas with prevalence of anemia and in tribal areas, and they also have areas where sickle cell anemia is more prevalent. Now, we learned about a slogan, again from Madam Sulan Miller, that donate one in the name of your own mother to save the mother. And since then, we have taken up this initiative through the Bangalore Society of Obstetrics and Gynecology. We buy this garment and we distribute it to the different hospitals where it is still not available, and we train them also. Now, NSG is still not introduced as such in government guidelines, but every state has been given the permission to procure. And government of Karnataka, that is the state where I stay, I'm in Bangalore currently, which is the capital of Karnataka, is going to procure 9,000 non-pneumatic anti-shock garment to facilitate every facility. Now, currently, if we look at the maternal mortality of India, has definitely come down. It is 88. Okay, per 1 lakh live births, and which has shown a declining trend. And that is, it was 97 maternal deaths per 1 lakh live births from 2018 to 2020. And we have seen now that in our, the maternal death review, as well as the statistics also, at least if you can look at this map in South India, in Maharashtra and in Gujarat, that the deaths due to postpartum hemorrhage have come down. Now, the hypertension during pregnancy or HTP is still remaining the first cause for the maternal death, and PPH has taken a second commonest cause for maternal mortality. So that shows that definitely the people are aware and they are able to use these garments, as well as once the patient has not responded to primary treatment of postpartum hemorrhage, they know that now they have to, that it is a refractory postpartum hemorrhage, and they have to start managing the patients in a better way as the guidelines and the protocols are there. So, and our own experience in a district hospital where I work in Bangalore, we have 2 garments. We have one in operation theater and we have one in labor room. And we are also using it for cases like ectopic pregnancy, where they come in a state of shock, and we really find it very helpful, as well as in cases of hemorrhage post-abortion, because we know that the abortion is legalized in India, but we get patients who are in a state of shock, and we have used in them also. And even when we are referring them to tertiary care center, we apply the garment and refer them. And when the patient is bleeding and we are still waiting for her to shift to operation theater, till then also it can definitely help to save the blood loss, because we know that the blood banks are not easily having all the blood and blood products. And we want to prevent a massive blood loss, because then it becomes unmanageable, where patient will require massive blood transfusion. She will require blood and blood products. If it is a minimal blood loss, the patient can definitely withstand. The another thing is, in India, percentage of anemia is almost very high. About 52% of women are anemic. And we know that the anemic patient particularly cannot withstand even a 300 ml blood loss. Like, even though our definition of postpartum hemorrhage is following vaginal delivery, the blood loss of 500 ml or more, but an anemic patient woman cannot withstand this. So in these patients, once we diagnose postpartum hemorrhage, it is better we apply it so that she does not lose more blood and we are able to stabilize her early. Yes, the anemia could be mild, moderate, or severe, but the anemic women cannot withstand even a average blood loss, which we say in a normal woman will be able to tolerate before going into shock. So these are the scenarios in India, and most of the states have it. And why you can look at the maternal mortality in the states south. We know that south is doing better compared to the other states of India, and that is because of again the women empowerment and the literacy matters. But now overall the maternal mortality is coming down, and I think every state government has taken an initiative to achieve the SDG goal, which all of us we know that we should have a MMR below 70 per 1 lakh live births by 2030. Most of the states have achieved, but uh, we through FOXY, that is our Federation of Obstetrics and Gynecological Societies, as well as the other committees like Safe Motherhood, Practical Obstetric Committee, as well as I'm the chair-elect for the Indian College of Obstetrics and Gynecology. We do conduct online program and we are trying to train more and more people. Now, I think all of you are aware of these garments. It has a 6 segments and it can be easily applied, and the training is not so difficult. Even when we are applying to the limbs, yes, you will require 2 people, but the segment 4, 5, and 6, one person has to apply. What is need to be followed is the removal, and that is why the training is very important, because we have to be sure when we want to remove the garment. Now, the way it is applied, it is applied below the lower rib, lowest rib, so that the patient do not have any difficulty in breathing. And the way it is made up is that we can put the patient even in lithotomy position. So if we have to do any procedures, like if there is any patient requires any procedure due to incomplete abortion, or if there is a tear, vaginal tear, cervical tear, we can suture it. If we think that the patient needs laparotomy because she continues to bleed, she may need surgical management, we can shift the patient with the garment on her to the operation theater. There, we have to remove only 4, that is the 4 one is about 3, 5, and 6. And 5, you can see there is a ball in that, and 6 is wrapped over that. So if we have to do laparotomy, we will have to remove only 4, 5, and 6, and we should proceed with the surgery and again reapply that. Now, coming to the removal of this, we have to see, yes, no question of removing it for 6 to 8 hours. After 6 to 8 hours, we see that the patient is stable. She's not bleeding anymore. Her pulse is less than 100. Her blood pressure is more than 100. And her all the vitals are okay. And that means, if her pulse and blood pressure are stabilized, that means what? The patient is stable. And in case if she would have had the blood loss, we could have given her the blood and blood proctors and corrected it. And hemoglobin at least should be between 7 grams to 8 grams per deciliter. After we start and removing, we remove the first segment, remove it and monitor the patient. We wait for 15 minutes to check the pulse and blood pressure. No change, we remove the second. Again, wait for 15 minutes, no increase in the pulse rate, no fall in BP. Yeah, that means our patient is stable. Then the third segment, by chance you find that after removing the third segment, the patient is having tachycardia, that means that we have still not stabilized the patient. She is still hypovolemic. So we may have to correct that. So nothing, no problem. Then again 15 minutes, remove the fourth. Again next 15 minutes, remove the fifth. So that way it might take more than 1 hour, 1 hour, 15 minutes to remove. And then we can remove the garment. And we have seen that we have saved so many others by using this garment, which is such a simple technology. And it can be reused. We know it can be reused 70 times. Yes, you have to wash it with a whatever bleaching powder solution. Now usually we carbolize the same way and we dry it up, and it should be folded and kept in a place where it is easily seen by all the health workers, so that as soon as there is an emergency, they immediately pick up the garment and they apply it to save the mother. So I must share this that this is one of the district in Tamil Nadu, and they in 2024, almost for a period of 1 year, there was not even a single mortality. And I think that is really commendable. Okay. And they also have all the facilities. And I must say, Tamil Nadu is one of the state where the even the post primary health care center, taluka, district, they are all very well equipped and very well connected. And the government is really working very hard. And the same example is being followed now by other states. Yes, Kerala definitely doing better than the every state in India. So this is the scenario, and I think definitely we go ahead. We will definitely have less and less number of maternal deaths, making the motherhood more safe in India. Thank you very much for your patience here.
Thank you so much, Sheila. This was wonderful. It's really, I think India is one of the only places where it's gone, like the scale up has gone so smoothly, as far as like the different states taking it on. Because many other countries it begins, and even if they are happy with it, it doesn't go this smoothly. When it's presented to someone, like we show it and we say, you can use this, not everyone immediately says, this is going to work. Some people don't ignore it. I mean, some people ignore it, So what was your impression,
Yeah.
and why do you think it worked well? Mm-hmm.
See, it is worthwhile in countries where, particularly, I will come to tertiary care centers later, particularly in periphery, where they have to
Mm-hmm.
shift the patient. It could be
Mm-hmm.
15 kilometers, it could be 20, it could be 50 kilometers. But the
Mm-hmm.
patient is bleeding, and by the time she reaches, she is in a stable condition because if we have applied the garment, it will reduce the blood loss from the pelvis.
Mm-hmm.
Okay. So, and
Mm-hmm.
yes, we are doing all other, we have done our medical management, we have started the IV fluids. Okay. And another
Mm-hmm.
thing is blood and blood products are not easily available even in a taluka hospital. Okay, they have stabilized the
Mm-hmm.
patient, but they know patient
Mm-hmm.
continues to bleed now and they cannot manage. So
Mm-hmm.
if they apply this garment and the patient is referred, at least
Mm-hmm.
till she reaches the facility. And the best
Mm-hmm.
part is anybody, even a ancillary midwife and a nurse, anybody can apply. Okay, so any health
Mm-hmm.
worker can apply it. We don't need a lot of expertise for that. The training is so
Mm-hmm.
simple.
Mm-hmm.
And I mean, now when we are doing the maternal death review, those who have and have not used, we are asking them the questions. Why didn't you think of using it? You could have
Mm-hmm.
saved the mother and you could have reduced the morbidity also. So,
Mm-hmm.
and the other indications we are telling them. We are using it in ectopic pregnancy, in post-abortion cases where there is a hemorrhage.
Mm-hmm.
Then
Yeah.
in midterm, when there is an antepartum hemorrhage, where the uterus is
Mm-hmm.
not so big, but at least we
Mm-hmm.
can shift her to operation theater. Till then, we can use it. Then after the surgery also, if we have not used it before and we find that she is
Mm-hmm.
still bleeding, we can still apply it if she is in a state of shock and then shift her to the ward. So that way,
Mm-hmm.
what I feel,
Yes.
in spite of doing all the measures, if the patient has
Mm-hmm.
hypovolemia, the
Mm-hmm.
major organs like the heart and brain has to
Mm-hmm.
get a better blood supply to keep her stable, to maintain
Mm-hmm.
her blood pressure.